Our speaker today is Dr. Michelle Weddle. She is a third-generation dentist, which I think, Roger, you are too, aren't you?
I am.
She graduated from NYU College of Dentistry, and then she did a GPR at Newark Beth Israel, which I'm familiar with that program, great program. And she runs an airway-focused practice with 2 locations in Watchung and Elizabeth, New Jersey. So I've been hearing about Dr. Weddle for quite a while. I have not seen her lecture before, but I'm excited to turn this over to her for her lecture, Pediatric Airway and TMD Issues, the Dentist's Role in Screening. Dr. Weddle, it is all yours.
Thank you so much, Dr. Park, and thank you for having me here. So let's get started. I'm just going to make sure that I'm sharing my screen. Here we are, Pediatric Airway and TMD, the dentist's role in screening. So this is our objectives for today, kind of a lot, but we'll just go through it. I wanted to present this from a perspective of a general dentist or a dentist that is seeing an adult patient. And we're kind of going to bring back time for that adult patient, because a lot of the things that we see in the adult starts in kids. So I'm going to start with the ADA position statement. Back in 2017, the ADA has kind of have a position where the dentist's role in screening airway in adults and kids have been established. So basically, we're going to screen, we're going to look for risk factors over here. So we're looking at other risk factors that may lead to airway issues. So first, we're going to screen the history and clinical exam, find signs that might identify that patient as having any kind of deficient growth and development. So we're going to go through that today, and other risk factors. So let's get going. Pediatric dentistry also is saying the symptoms of OSA, this is a good list, includes excessive daytime sleepiness. Now, excessive daytime sleepiness is not always the case in kids, because there's also another aspect of that. So if anybody has had kids, you can understand if they're past their bedtime and they're really tired, they tend to get hyper, they tend to not listen, they tend to get a little bit more emotional. They don't want to miss anything. So they kind of just want to keep themselves up. So there's that other iteration of sleep apnea or sleep disordered breathing in kids that's not quite like the adults, where the kids tend to be more hyper and not falling asleep all over the place. So excessive daytime sleepiness is not always the case. But these are other signs and symptoms: loud snoring, 3 or more nights per week. Rare, but sometimes you can hear breathing, and then they stop breathing, right? Cessation of the breathing, and witnessed by usually the parent or the caregiver. This is important because sometimes in school, when the kids are young, they take naps. So that's usually where the caregiver or the teacher can find that out. Awakening with dry mouth or sore throat, morning headaches, difficulty staying asleep, attention problems, mouth breathing. And mouth breathing is super, super important. And one of the things that is one of the easiest things to spot, especially when you have patients come in, adults or kids, sweating, restlessness, and waking up a lot. And this was adopted in 2016. So let's just kind of go back and look at just what can we see as dentists? So there's a study out of Finland, 491 children, 6 to 8 years old, and they looked for just signs: frequent snoring, apneas, open mouth posture in the children while they're awake, the open mouth posture. And they factored in BMI, the bite, and a sleep survey. And what they found that there is a 10% prevalence in children where they have signs of sleep disordered breathing. And they didn't find any difference in kids who are overweight or obese, or between boys and girls. So now, what are the factors that they saw? So they saw tonsillar hypertrophy as one of the things that's most common. So if they see tonsillar hypertrophy in kids, it's 3 to 7 times more likely that child will have sleep disordered breathing. If they have a crossbite, if they have a convex facial profile. Obesity and BMI didn't really factor in this study. So that facial profile is that retrognathic mandible, that convex facial profile. This is the highest risk. So if we have kids that are walking into our practice and you can already see that their mandible is back, that's a risk factor. That doesn't mean that they have anything. That's just for sure. That just means that it's a risk factor. So what they're saying is that the abnormal craniofacial morphology, but not excess fat, is associated with an increased risk in SDB in 6 to 8-year-old kids. So really in the dental office, if we want to simplify things and screen all our patients and especially our children, this can be done in the hygiene chair where we're looking at these factors. So again, what are the factors? Going back, tonsillar hypertrophy, crossbite, and the facial profile. 3 things. Very, very easy to spot in less than maybe 2 minutes in a dental chair. So when you have an adult walking into your office, and this is a patient that presented to the office, and they were referred to the practice because they have sleep apnea. So they wanted to obviously get more restful sleep, feel better during the daytime, when they're getting restful sleep. But if you look at her malocclusion, a lot of times we're looking at it and we're saying, wow, how does this lady function? She eats fine. We see a lot of these patients, right? They have bites that are not quite even, bones that are asymmetrical, but functionally they're doing pretty well. Once in a while, you can see patients that have perfect occlusions, and they also have pain. So it's not necessarily the occlusion that leads to TMD pain or symptoms. And when we're looking at a patient like this, we're saying, all right, well, where do we start? And I would say that in a patient like this, when there's some bony asymmetries, you have malocclusions, the time to start is really when they were much younger. So a little bit about my practice. I practice with my mom. As Dr. Park said, I am a 3rd-generation dentist. Both my parents are dentists, and we have general practices. And I also have a TMD and sleep only practice. So when we look at my general practice, I have more about 65% of my practice is adults, 35% is children, but we see a lot of families. So when I first started this journey, I was seeing the adults and I was seeing them with sleep apnea, I was seeing them with TMD, and then I would see their children and I would see that the malocclusion was developing, and the same things that I'm doing in adults. So for example, if I have an adult that has sleep apnea and they have a retrognathic mandible, and we're going to make an oral appliance. Now we know that oral appliances, we're trying to move the mandible forward in order to open up the airway. So if I see that in an adult and I see their children having developing malocclusion where the mandible is retrognathic, the palates are narrow, high arched, the referral to the orthodontist is made almost more important, because we're looking at malocclusions, yes, but also I'm looking at kind of down the line. I know that this patient has a risk factor, familial tendency, genetic risk factor towards progressing and manifesting obstructive sleep apnea. So that kind of was the beginning of my aha moment in general dentistry, when you see families and you see the parents and then you see the kids and you can see kind of, oh yeah, I can see how that can lead to this. And I'm sure, I don't know how many of our audience have that situation where you have a practice that you are actually able to see the parents and the kids. So, like maybe say in the chat box how many of you guys are having have a family practice and are seeing that pattern in your practice. And also, anybody who's doing TMD, screening for sleep apnea, chime in and write in the comments box. And later on, if you have any questions, let me know. So here is a patient that presented to the practice for just a regular checkup, and this is what we see. So in the hygiene chair, I'm looking at this patient, and we're looking at of course, with very worn down teeth. But if you look at the mandibular molars in this area, you can see that these molars are severely inclined inwards. So in a case like this, on the posterior, he doesn't technically have a crossbite, but if you can imagine these teeth, once they upright, they can, then can you kind of see that this is going to manifest into a crossbite. The same thing here, this is about edge to edge occlusion, maybe a little crossbite. Definitely here on the canine area, there's a crossbite on the anterior. So if those molars in the back weren't inclined inwards, you'll probably have a anterior and a posterior crossbite in this area. Another way to look at this case in your patients is to just look at the molar area here and ignore the teeth for a second and just look at the bone. So if you look at the bone here and you look at the bone here, right, so they're pretty equivalent. Maybe the mandibular bone is a little bit in, but we really want that maxillary bone to be out 4 or 5 millimeters buccally to that bone of the mandible. So we know that this maxillary arch is narrower for this particular patient, considering the width of this patient's mandible. So again, we're kind of just screening. So remember, one of the craniofacial morphology that we were looking at is if there is a crossbite. So this is one of those where it's a masked posterior crossbite, and there is an anterior crossbite, and then you see that there's some bruxism here. If you look at the posterior teeth, it's really not worn down as much as the anterior. So the pattern of the bruxism of this patient is an anterior protrusive kind of bruxism. So again, if you would imagine, what is our treatment for sleep apnea in the adult? We're actually moving that mandible forward. And it seems like this patient might be trying to do that themselves. So again. All right, so what did I do? For this patient, I screened, and then, back then, this is 2013, back then I was referring to the pediatrician. So doctor, I wrote to the pediatrician. This patient is a patient of record in our office. During his checkup visit, he presented with dental conditions that may indicate a sleep disorder or sleep apnea. So here I would probably now put risk factors, right? I am referring for evaluation, tonsilous area, possible referral to ENT. And then here are my findings. Tooth, bruxism, acid attrition, mouth breathing, tonsillar grade, slightly large tongue, maxillary arch width appears inadequate. That's typo. That's inadequate. So now, when we look at this patient here and we're referring to the pediatrician, you're really looking at the pediatrician's almost approval or almost making the pediatrician the gatekeeper. And some pediatricians are happy to do that, and some pediatricians, it's not part of their practice. So now what I'm finding is more effective is I send and I refer directly to either the ENT or the sleep doctor, the pediatric sleep physician, and not necessarily the pediatrician. I will loop the pediatrician in, but the referral will be directly to the ENT, especially with large tonsils, directly to the ENT, and then the pediatric sleep physician. All right, so back to our patient that is an adult, right? So when we're looking at an adult patient, looking at craniofacial structure, right? So we're looking at symmetry of the face here, symmetry of the eye. So in this patient, we're looking at it, it's not so asymmetrical how in the eyes and in the upper face. Mid face, not quite, it's not really that asymmetrical. Maybe the nostril is bigger in this area than here. But when you look lower face and we look at where the chin is compared to the middle of the face, we can see that that chin is off towards the patient's left. Right? And then when we look at the teeth, then we can appreciate the asymmetry of this bone, the maxillary arch, and you have a cant. And a lot of times when you have a cant in the bone, it's one of the hardest things to do to fix orthodontically when you're trying to do fixing the cant either in children or in adults, especially when you're using modalities such as clear aligners. So, and then in this profile, what we can appreciate for this patient is that the maxilla is here, the mandible, the chin is back a little bit a ways. And then also we can look at posture. So we can see forward head posture on this patient. She's leaning forward, and you can see a little bit of a hump developing in the back where that musculature has developed. So these again are risk factors. When you're looking at adults, these are risk factors or things that you can see if you pay attention. You can see very easily because you don't have to have the patient in the chair. If you go to the airport or the train station, you can actually see all these patients with their profiles, and you can kind of look and assess the risk. So when we're looking at that hump and we're looking at that forward head posture, a lot of times the body also will reflect certain things. So it's almost like a stack of blocks, right? So when we look at a stack of blocks here, we're trying to see, okay, if we cover, so when we're looking at the body here, we have the back and then it goes inwards and then goes down. So if we equate the body to a stack of blocks, and we're stacking the blocks and we want everything straight, but what if one is off? Then in order to balance everything, the others have to compensate. And that's kind of what we see in the body. So if we even if we cover the head of this patient in the photo and just look at the body, we can kind of see, all right, maybe there's something off with the head posture where the posture is more forward, because you can see the compensation in the rest of the body. So that's another screening mechanism when we look at posture. So let's see. And then when we have that posture of the forward head posture on this patient, if you look at the airway space, moving the head forward gives you a bigger airway space, and having that head in an upright posture with the rest of the body will give you a smaller airway space. And you can really see that mandible is a lot further back when they actually don't compensate for the posture. So a lot of times, I don't know if you can see me, my head, but when the patient moves forward here, their gaze starts to go down. So what happens is they rotate the head and they go like this. So it's not just forward head posture, but the forward head posture is there, but the head is tipped upwards. And that head being tipped upwards gives you an illusion that that mandible is kind of in the right spot. It's nicely and well balanced with the face. But then when you correct for posture, you can kind of see really where that mandible lies. And then you can see the narrowness of the airway space. Now, again, this is a CBCT of an upright and awake patient. It is not an indication of what their function is. It is an indication of the size and volume of the airway space during this one screenshot in time. And we know that when the patient breathes in, they breathe out, they swallow, this dimension is going to change. Functionally, this is a very dynamic space. But what we're looking at is upright, awake, how big of a space. That's a risk factor, because then if you imagine if the patient is lying down, asleep, muscle tone is a lot more relaxed, could this be smaller? So it's all risk factors. And actually for this particular patient, when we put them in that position, they said they can't breathe. And that's why like this. So for a lot of these patients, when they go through physical therapy, they have neck issues, they have back issues, shoulder issues, and then they go through physical therapy. A lot of times the physical therapist wants them to stand upright, put the head back. But then if you think about it and the patients can't breathe, it's not something that's necessarily going to take. So how did the patient get here? Growth is how the patient got there, right? So then what factors in with the growth? One of the things, the topic of this presentation is TMD. So let's orient ourselves. TMD, basically condyle right here. Inferior head of the lateral pterygoid. So you have muscle, you have bone, and you have disc, right? So again, imagine ball here, socket here. So ball and socket joint, kind of, right? So ball, socket, disc in between. This is the ear canal, which makes this the front of the face. And when we have the condyle, so condyle, disc, fossa, those are the three articulating components of your TMJ. And when you hear clicking in your TMJ, that is the articular disc moving in and out of position. And then now the other thing is, if you look at this, ball, socket, disc, back here is retrodiscal tissue. And in the video that's coming up, we'll see what the implication of that is if the articular disc pops out of place. And then this is just another image looking at it from a coronal view, condyle, fossa, disc, and that disc is right in the middle. Now, from the sagittal view, if you look condyle, fossa, disc, one thing to appreciate is that that disc is not in the middle like it is in the coronal view. It's not like right on top, right? It's more towards the front, top and the front. It doesn't cover, the back is not covered. So, okay, now we have a normal joint here. Ball, socket, disc. And that disc looks like a doggy bone almost, right? Or a ribbon. So in a normal function, when you open widely, this is what's happening here, that condyle translates and then it goes back. All the while that disc is staying in place. So there's a little rotation there and then some translation. So coming back and then it rotates into place. So the rotation happens up to 26 millimeters in terms of opening. And then once you translate after 26 millimeters, that condyle is moving forward. So that's a normal disc. Now you have a disc here that has a reducing disc displacement. So again, condyle, fossa, disc is here. And then once the disc seats in place, going back. So let's see. Coming back here. So I'm replaying that. So we're going to open a little bit. Now it pops in place. Now it comes out, translating. It's still in place and it seats and it pops out of place. Can you see that? And every time it pops out and goes in, there's a click. And a lot of times that click is louder in this right there. As you open, that's the click, right? So that's a reducing disc displacement. Then the disc reduces anteriorly. Is displaced anteriorly, and reducing means it goes back into place. All right, so non-reducing disc displacement is here. Basically, you've got ball, play the video, ball, socket, the disc is here in between, and that disc is kind of out there, right here, and it's not really picking up, right? So right here, sorry, that's your disc. So now you can see that it's bone on bone rubbing, and you can see the roundness of the condyle here where it's normal. That roundness of the condyle is no longer. It is more flat because of that rubbing. And then in degenerative joint disease, you've got really no tissue in between and you're just bone on bone rubbing. So here is your progression of joint derangement. So now why do we have to worry about joints? In children, when they're growing, this joint, this area here is your growth center. And when that disc is not in place, the growth of this mandible is impaired. So the downward growth and the forward growth of the mandible is dependent on this area growing. And if they don't grow, then you're not going to get the downward and forward. And that's when you start manifesting one of the biggest risk factors of airway issues, which is that retrognathic mandible. And this is just a growth of maxilla. And we know that the top and the bottom bones are growing independently, but also they grow together because they talk via the teeth. The teeth are always wanting to align themselves and put themselves together. So despite the fact that the growth of the maxillary arch is dependent on the laying down of bone here, and the growth of the mandibular arch is dependent on the growth of the bone in the condyle, they are also trying to coordinate with each other via the teeth. Now, in kids, a lot of the times, one of the things that derails the growth is trauma. So, trying to move some controls out of my screen.
I will. Ready for you, Gracie. Oh.
You giving her a kiss?
So as early as this age, we have some events that can lead to just the pushing of that mandible. And a lot of these events
Okay.
have the potential, a lot of these events have the potential to pop that disc out of place. So a lot of the kids might already have this. And one of the signs is clicking of the jaw joints. So when you're screening your pediatric patients, have them open and close. And a lot of times, if the clicking is there, you know that there might be a risk for impaired growth. So what happens if the discs are displaced during growth? The phase changes and the occlusion changes. So a lot of times we thought, well, I was taught in dental school that TMD issues are caused by malocclusions, early interferences, in the bite, things like that. But now we're actually finding out that maybe that bite, maybe that malocclusion might have started because the discs were not in place. There might have been a TMJ injury or a TMJ problem well before the malocclusion. And then the malocclusion happens, and then over time, compensations happen in our patients as they get from childhood to adulthood. And then it becomes symptomatic, especially if you add on to the mix the fact that that mandible not growing well is a risk factor for airway issues. And if that patient does manifest airway issues, now you're adding more compensations. If the jaw wants to clench, the jaw wants to reposition forward, you're doing a lot of functional compensations that puts more stresses to the muscles of the face, and the joint. So TMJ derangements are both common in children and may contribute to the development of retrognathia with or without asymmetry in many cases. And the thought that malocclusion was the cause of TMJ issues, but it could be that the TMJ injury is the original cause of the malocclusion. So when you have a patient past puberty presenting with that mandible not growing forward at all, the first thing to look at really is the joint. Now, this is a patient, this is an adult patient, and if you look at the CBCT, you can see that the condyle is longer on the patient's right compared to the patient's left, right? And if you look at the upper face, everything is pretty symmetrical. And then you start going here in the mandible, and you can see that this growth has been derailed by something happening to the condyles, the growth of the mandible. Everything else is pretty symmetrical on the top. And then if you look, that's that chin off to the left because that mandible is off to, that condyle is shorter on this side than on this side. Okay, so looking at the Piper classification of joints, 1 is normal, 2 is intermittent lateral pole displacement, could be caused by ligament laxity. You have 3A and 3B. 3A is a lateral pole displacement with reduction, and 3B is non-reducing, but it's all in the lateral pole. 4A, again, it's a non-reducing displacement, but it's on the medial pole, which is really where the forces of the jaw articulation happens. So it's more consequential if that displacement is on the medial pole. 4B is a non-reducing. 5A is no disc, bone on bone, and the joint is adapting. And 5B is no disc, bone on bone, and that's adapted. Okay. Clicking, pain in the joints, muscle tenderness, deviation on opening, and then range of motion. So these are the things that we're going to screen for.
Okay, big smile. Show a lot of teeth. Okay, good. Open really wide. Keep showing your teeth and close. Big smile. Keep smiling. Open again real wide and close.
Okay, so this is a teenage patient and she presents with malocclusion. My teeth are crooked. I want to have a straight smile, straight teeth, pretty smile. And then when we screen for TMD issues, one of the things that we look for are deviations when they open. So I'm going to go here again. And here we can realize that the midline is pretty well coordinated.
Okay, good. Open really wide. Keep straight.
Oops.
Big smile.
Sorry.
Show a lot of teeth. Okay,
I'm going to pause right there.
Really wide.
Actually,
keep showing your teeth and close. Big smile.
When she bites down, so here, when she opens wide, you can actually see this is the midline, this is the midline here. She's starting to deviate her jaw towards her right. And I'm just going to move forward. At the maximum opening, this is her discrepancy. So what she has is a disc that is out of place, right? But it's not going back into place. So the disc is out of place on her right side and it's not going back into place. So again, if you think about, come back to me if you're looking at your screen. And if you think about 2 people with a pane of glass and one person is on one side, one person is on the other, and they're both carrying this glass and they're walking forward together, the glass is moving with no problems, right? But if, for example, one person, both people are walking and one person decides to stop and they're still holding this pane of glass, the other person is still walking, in order for those 2 people to keep that pane of glass intact, this person who's walking is now going to have to move towards a person that's not walking, right? So the jaw, the mirror, is going to the side of the person who's not working. Well, the jaw is going to the side of the joint that is not working. Now, if it reduces, if you hear the click, once it reduces, this goes back to midline. So that's one of the things that you can look at in terms of function and clinical screening. If the jaw, as the patient is opening, is deviating to one side, you know that there's a disc that is displaced. If on maximum opening, that disc stays on that side, the jaw stays on that side, then you know that the disc didn't come back into place. It's just not working, and it's still not working on maximum opening. But if the patient is opening and you can see the deviation, but then you hear a click and then it goes to midline, that's an indication that that disc is recapturing. So hopefully that's clear. All right, so what are we going to do? We're going to screen for range of motion. We're going to screen for popping and clicking. We're going to screen for developing jaw relationships and posture. And in the airway, we're going to screen for mouth breathing, again, posture, so they have that too in common. We're looking at medical and social history and craniofacial structure. All right, so how do we measure range of motion? So there's a range of motion ruler that you can get, and it looks like a curve. And if you see, there's a little notch in the bottom, and you're going to put that on the lower incisor, and you're going to have the patient open wide, and then just look at and see where the maxillary incisor edges are, and that's where you're going to read the number. So in this situation, this is 30, 35, 36, 37. So this patient's range of motion is 37. Actually, they're opening more, it's about 38. So that's your maximum opening. Now, we also are going to screen range of motion on a lateral excursion.
And move your bottom jaw all the way to one side. Hold it there. It's about 8 millimeters, 9 millimeters, 9 millimeters. Okay, go the other way. About 8 millimeters.
All right, so we're going to play that again.
Move your bottom jaw.
And what you're going to do is the midline of the upper arch is going to be aligned with the midline triangle of this ruler. And then you're going to have the patient move to one side. And then you're just going to see, so this is the patient's left, so left lateral excursion. When you're moving to the left, you're checking the right joint. This joint is the one that's working. So now we're looking at the number here. This is the midline again of the central incisor, coordinating to about 9 millimeters. So your left lateral excursion is about
8 millimeters,
9 millimeters. Okay. Now again, we're going to go the other way. So this is a patient's right lateral excursion. We're testing the left TMJ. So my ruler is a little bit off here. We're going to align that a little bit better.
And move your bottom jaw all the way to one side.
And here you're looking at about 7 to 8, somewhere between 7 and 8 millimeters on the patient's right lateral excursion. Normal range of motion, wide opening, somewhere around 42, 45, that's great. Left and right, we want them to be 10 to 12, 10 to 15. So this patient has a limited range of motion. And the range of motion in kids is very variable. So if you take a look, children and adolescents values from different studies, maximum opening 43, 43, 45, 47, 52. So you can see 36, 35 at the low end. So that's from Istanbul. And in India, you're looking at boys and girls, different age ranges, ranging from 46 to 52. So there's a big variability. What does this mean? In kids, if we really want to know and we want to guide their growth and we are suspecting that there's something going on, very similar to the pediatrician where they have the height and the weight percentages. There is a chart available where from this study, they studied 20,000 school children and they looked at minimum and maximum. So 97 percentile, 3 percentile. And these are your ranges over the age range of your patient. So it's great to plot this to understand where your patients lie. So there's a chart for boys, and there's also a chart for girls. Now, posture. So we did appreciate earlier the effect of posture in the airway space. Here we have a study, condylar position in deliberate forward head posture is significantly more posterior. So when that condyle is more posterior, that disc is more likely to move forward and displace. Activity of the masseter and digastric muscles in deliberate forward head posture was slightly increased. And results suggest that condyles move posteriorly in subjects with forward head posture. So now you have, again, the chicken and the egg, right? So you have a patient with a small airway maybe, and they're posturing forward. And because of that, that posture reinforces that condyle being back, that disc moving forward, and perhaps affecting the growth of that mandible even further. The other thing is, if you look at the image here, we have our patients and us, our adults, glued to our phones a lot, and that promotes forward head posture, sitting on a desk, glued to our computer screens and our keyboards. That also promotes forward head posture. So a lot of times our posture tends to affect our TMJ also. So can temporomandibular joint disorders be diagnosed beforehand by assessment of postural irregularities? So basically, this is a cross-sectional study. Children 4 to 14 years old, they did a TMJ exam and the relationship with forward head posture and also different shoulder levels. The primary dentition, they didn't find a relationship with forward head posture, but they did find a significant relationship to different shoulder levels. Mixed dentition, both forward head posture and different shoulder levels had a significant relationship to TMJ issues. And in the permanent dentition, no relationship. I'm thinking this is probably already, they've cinched in, everything has already been compensated. They're not finding any relationship. So since there is a strong relationship between postural irregularities and TMD, especially in the mixed dentition stage, TMJ and postural status of pediatric patients should be examined as early as possible in the stages of life. In this regard, the awareness of pediatricians and pediatric dentists in this matter needs to be improved. And I'm going to add onto that hygienists, right? Because a lot of times the hygienists or the assistants, they're the ones that are walking your patients to the chair. So the posture is much more evident. And a lot of times the dentist walks in and the patient's already in the chair. So you don't appreciate the posture as much. So this is a patient. He comes in walking like this, different shoulder heights, forward head posture. So when we're looking at posture, we're looking at the middle of the shoulder. We want to draw a line there. We want to find the ear in that vicinity. So this is a forward head posture for this patient. You're looking at the muscles here, working harder because the weight of the head is being carried forward. And then when we take a CBCT, a lot of times what we'll try to do is correct the posture just to assess risk factors for that airway. So there's something called juvenile idiopathic arthritis, and we can screen for that. This is one of those things that we just don't know, and we're not understanding why there's some kind of TMJ issue. In patients with juvenile idiopathic arthritis, we are finding resorption of the TMJ. There's also something called idiopathic condylar resorption, and that is a situation where we're not aware of what's happening and why that condyle 1 or 2 are resorbing. A lot of times what we're finding is that there is a history of trauma to these patients, but if you saw the video earlier, a lot of those babies, we don't think anything of it, those little spills that they take, but they're enough to really cause some trauma to the TMJ. So when we're screening for the TMJ, this is our screening form. Do they have problems chewing? Are they slower to eat compared to other relatives? They bite hard food with difficulty, pain while eating, limited mouth opening. Our examination, limited mouth opening. So here, history, limited mouth opening. A lot of times they'll say, I can't bite through a sandwich. I can't open my mouth wide to put my teeth around a sandwich, especially if it's multi-deckers. Limited mouth opening, crepitation sounds when they're moving their jaw forward and back or side to side, pain while they're opening, and deviation on opening. If there's any kind of asymmetry happening on the bone, maxillary mandibular, and also retrognathia. So these are the things that you screen for. In addition, the range of motion and pain in the joint or muscle tenderness. So what do? We can do a couple of things in our practice. We can choose to just do nothing but screen. We screen our patients, we identify who is at risk, and we're going to refer. We refer to orthodontists or TMD specialists, pediatric dentists that are able to monitor and help growth and development of these kids. Number 2, you can do some some kind of primary dentition management. You can do some function like oral appliances, preformed appliances, see whether they can breathe through their nose instead of their mouth, some splint therapy if there's some disc that are clicking. That's things that you can do. Or you can say, I'm going to do primary and transitional dentition. We're going to focus on structure and function. So here you're going to do some myofunctional therapy, some splint therapy, maybe some expansion. Or you can do all. So just like any other specialty in your practice, how do you determine who to do the root canal on or who to refer to the endodontist? So same thing here, depends on your education, whether you want to do the procedure or not, what is your office's capability with regards to supplies, staff, equipment, things like that are things to consider. Do we want to do all of them, right? So do all. You're going to manage structure, function, and structure and bone. So those are things that we can do in the practice when we see these kids. It's just a choice depending on what you want to manage. So at that, I'm going to open it up to questions.
Thank you, Dr. Weddle. Let me get my camera turned back on here. Thank you so much. That was a very interesting lecture. You covered a wide range of issues as far as pediatric airway and TMJ. And so we do have some questions I want to share with you. So what is your recommendation as far as children who do a lot of grind their teeth? I mean, is that an indication that there is some kind of breathing disorder or TMJ disorder? Where do you see that?
Yeah, so when there's bruxism, one of the things that we want to know is there an underlying airway issue? And airway issues are easy to screen with some screening forms. You can even have the parents see whether they can record snippets of the patient sleeping. It's easy to uncover because a lot of times all you have to say is, "Oh, how does little Johnny sleep?" And then a lot of times the parents spill the beans.
Right. But I mean, like, if you had an adult that answered the questionnaire a certain way, you might go ahead and start appliance therapy. But with a child, appliance therapy is much more complicated, right? Because you've got growth and development going on. What is the treatment? Where do you go? Do you refer them to an orthodontist, pediatric dentist?
Yeah, so regardless of what the sleep or airway diagnosis is, right? Because that's one aspect. We do dentistry, right? So if there is some malocclusion, crossbites, the bone on the bottom is not matching the bone on top, then we want to modify and help grow that patient to a more optimal or ideal. So pediatric dentists, orthodontists, or general dentists that do growth guidance, expansion, some orthodontics, those are the people to refer to.
So I've noticed that some orthodontists, for example, are much more airway attuned than others. I think in your area, I've got an old friend, Barry Rayfield, that's a very airway oriented orthodontist. I mean, how do you know that the orthodontist you're referring to is someone that is attuned to this?
A lot of times they're saying that on the website now. So it's really easy to just kind of slide, go on the website and know who around your area is an orthodontist who is airway aware and is looking at orthodontics from both malocclusions and airway.
And get the orthodontist to take you out to lunch and talk about his or her treatment philosophy. I think that's another idea too.
You can totally, yes. So pick up the phone, say hi. A lot of the orthodontists do reach out to general dentists. So, the dental society meetings, right? So if you go to dental society meetings, study clubs like this, you'll know from the comments of the individuals who is more airway aware and who isn't. So yes,
exactly.
But definitely talking about treatment philosophy because everybody has their own treatment philosophy and they can practice differently. So even general dentists, right? One is more family dentistry. One is more, I love to see peds. I love to see just adults. Different ways to practice.
Exactly. Okay, another question. We see a lot of kids that walk around with sort of an open mouth posture. They just, they don't have their lips together. Is that an indication of something?
Well, it's definitely a mouth breather, right? So now the next stage to that is, okay, you identify a mouth breather. Now, is that mouth breather a habitual mouth breather? Do they have to or do they have to breathe through their mouth? So there's a 3-minute test. You can take like a business card or just any kind of like paper towel, tissue, and have the child just sit with that and just make it a game in your chair. So while maybe you're looking at x-rays or trying to write up your chart notes, you're going to say, oh, let's play a game. I'm going to have you hold this card on your lip and we'll see how long you can hold it. And then if 3 minutes passes by and your child is not panicking or your child's not dropping the card going, right, or turning red, I'm like, is it over yet? Is it done? Did I win? So, that's a screening method to see whether there is an inability to breathe through the nose.
So let me ask you this, just to be super clear, because we are seeing a lot of people out there. So is there any situation in which mouth breathing is normal? Is there any situation in which an open mouth posture is normal?
No, it's common. Right? It's common. It's out there. A lot of people are doing it, but is it normal? No. How often do you want to eat through your nose?
Rarely.
And that's how often you're going to want to breathe through your mouth, basically, because we know that mouth breathing does set up a whole cascade of growth changes and also functional changes. Breathing through the mouth changes your sympathetic tone versus breathing through the nose. Puts your body into more of a fight or flight kind of mechanism versus your rest and digest mechanism. So heart rate, blood pressure, things like that are all affected also.
Excellent. Okay, now you did a really nice explanation of showing somebody, showing how to look at range of motion, how to do measurements, how to look at the deviation of the mandible laterally. What about if the midline is off even before opening? You look in and that upper midline and lower midline are just not lined up. What is that telling you?
Not really anything right away, because sometimes the midline being off before they open is because they lost the tooth early. If they lost the tooth prematurely, it shifts the position of the teeth, and it could just be that. So it doesn't really tell you anything about function.
So it could be dental, not skeletal.
Correct.
Exactly. Yes. Very good. Okay, it means you got to look further. Okay. Somebody, including me, thought those range of motion gauges that you used were really great. Do you have a place that we can get those things?
Any ortho supply facility should have it. Supply company, they should have it.
Great.
Ask your supply company. Yeah.
Okay. And here's a question that just came in. What about how would you approach a child that had some kind of a TMJ trauma? Either they were hit or they fell, but they clearly had some trauma to their TMJ.
So there is something called aqualizer. It's like little pillows. So a lot of times when the TMJ is traumatized, you're going to get that retrodiscal tissue and things are going to be inflamed inside. So almost like a bruise. So if you get a bruise, the last thing you want to do is poke on that bruise and keep pressing on it. But the problem with the TMJ is that every time you're putting your teeth together, you're kind of just pressing on that bruise, right? So if you can get that pillow in between the patient's teeth and just let them kind of hang out that way, it'll decrease the pressing on the bruise and it'll enhance the healing. And then from there, you can decide, is there a disc displacement or did the disc stay in place?
Thank you. Well, Dr. Weddle, it was a pleasure to have you on today. You have so much great information. We'll have to have you back and maybe go into some of these specific areas a little bit more. But thank you very, very much. It was a pleasure to have you. And thanks everybody for joining us today. And thanks to the panel for sharing their insight. And next week, we're going to have Dr. Timothy Kaczynski come back. And he's going to do a presentation that we've all been asking for, where he's going to dive into his vast clinical and teaching experience, and he's going to answer the most frequently asked questions in implant dentistry. So you don't want to miss that. Be sure to join us. Thanks, everybody. Have a great week, and we will see you next week. Thanks. Take care, everybody. Bye, Dr. Weddle.
Thank you.
Bye-bye.